Uh, Good afternoon, ladies and gentlemen. First of all, I'd like to thank the Sri Lanka College of Pulmonologists for the invitation to discuss some interesting case of ILD. So this has been labeled as ResFire. So basically, we want to kind of create some fire inside you. So the unique aspect of this discussion is actually the panel is not aware of these cases. I mean, they have not seen these patients and they have not no idea about what is going on, and as well as that you don't know what is going on. So basically, we have two difficult cases, difficult patients that we need your support to diagnose this patient and manage this patient. So during this discussion, that there will be several questions. At least about 18 questions that we'll be asking from the audience, and then so there's a QR code. You can scan the QR code and then give your answer. So there's no correct or wrong answer. So feel free to answer. You know, in ILD, it's everybody's uncertain about ILD. So embrace uncertainty, as I mean, our trainers are telling all the time. So just try to get the best choice, but don't do any harm to the patient. So try to do the best out of these options. So I'll introduce my panel here. It's my pleasure and privilege to introduce Dr. Vijith Senaratne, my mentor and trainer, my guru in respiratory medicine. Actually, that during the time that I developed the interest in ILD, and also Dr. Sumudu Palihawadena, our consultant radiologist at the National Hospital for Respiratory Valisara, and she has expert kind of radiologists in ILD. And Dr. Chathurika Dandeniya, we work closely, and she's a senior lecturer in medicine at Peradeniya University and consultant rheumatologist. So we do not have any conflicts of interest related to this presentation. And I'd like to invite Dr. Oshadi Kehelo Vitagama to present the case to you all.
Thank you, sir. And good afternoon, dear panelists and ladies and gentlemen. Let me introduce our first case study. Our patient, 29-year-old female who is married for 2 years. Her story started in 2021, where she presented with sudden onset shortness of breath, hypoxic, and received prolonged ITU care. Developed anaphylaxis to one of the medication during the ITU, and further she developed nausea and vomiting, one of the oral agent given for the ILD. And further, we noticed skin thickening, dry eyes, dry mouth, and Raynaud phenomena as well. In 2022, she has progress of shortness of breath from MMRC 1 into 2. And further, in 2023, she has stable shortness of breath in clinically, where MMRC scale was 2. Again, in 2024, she did not adhere to the treatment for 8 months duration. So now she presented with worsening of shortness of breath for the last 1 month duration with MMRC scale of 3. So in examination, her GCS was 15 out of 15, and so saturation was 92% on room air with a respiratory rate of 28 cycles per minute, and she had bilateral lower zone and respiratory crepitations. And her pulse rate was 96 beats per minute, and the blood pressure was 130/80. And there's no added cardiac sounds or murmurs, and rest of the systemic examination is normal. Here is our patient, which is before the disease with her consent of, and this is our patient after the disease, and this is her hands. So I'll introduce Dr. Amila Rathnapala, consultant respiratory physician, to continue the discussion. Over to you, sir.
Thank you, Oshadi. So we understood there are several problems in this patient. First, there are a few acute problems. She presented with acute worsening of shortness of breath, and also that we understood that she didn't adhere to her treatment. She stopped her treatment for a while ago, and then she has been diagnosed with multisystemic disorder, and we don't know what it is. Actually, we have some basic examination and clinical findings, and also that it looks like she has significant drug allergies. And now she has a significant psychosocial problem, psychological issue, that she has significant stress or due to a pregnancy expectation. She basically wanted to get pregnant. And the potential problems that we might have to kind of come across during the management is that she might be vulnerable for infections. She might have risk of osteoporosis. She might have the potential risk of progression to end-stage lung disease, and she might develop pulmonary hypertension in future. And also that we might have to decide on advanced care planning whether this patient would be a candidate for lung transplant. She is very young patient coming with the interstitial lung disease. So these are the questions and problems that we have to manage in this patient. So first question is what would be the reasons behind this patient's worsening condition? Please scan the QR code, and the 4 members will come to you with the QR codes actually, and then you can scan from them as well. And you'll be given about 30 seconds. Right. Yeah, so I think majority of is kind of voted as all of the above causes, and about 24% acute exacerbation or subacute progression. And I'd like to ask from Sir, and what do you think about what are the possibilities in this?
Worsening of shortness of breath could be either due to the lung problem itself or other outside the lungs. So if you think of lung causes related to the lung problem, I think the first thing is that there is the exacerbation of the underlying condition she has, and the infections. That also comes right up in the list, and thromboembolism. So in that way, then other causes can be extrapulmonary, like heart failure, things like that. So in that sense, I think this majority are correct, because
exactly. So you have to think widely. I mean, it could be due to the disease progression, it could be due to infections, it could be due to cardiac failure, it could be due to pulmonary hypertension. Certain instances, you might get pneumothorax as well, and the patient have fibrotic lung disease coming with pneumothorax. So this patient has undergone basic investigations, which we found that the WBC and disease is quite normal. ESI is about 74, CRP is 7, and serum creatinine is 0.5. Liver enzymes normal. CP killers we did because the patient has significant myalgia, and then we did ANA, which we found that 1 in 640, and it has been mentioned that it is a speckle pattern. I'd like to ask from Dr. Chathurika, and what are the patterns of ANA that we encounter during our routine investigations?
Thank you very much. So, ANA is one of the most important investigations to a rheumatologist when it comes to the investigation of a patient with possible connective tissue disease. Particularly in this patient who doesn't really have a clear-cut single picture. I would say, like, at a glance, you might think looking at her face, is this systemic sclerosis? Could be. But then there are certain other things that are that would take you away from just a diagnosis of systemic sclerosis to think, is there something else? For example, the presence of unusual 2 allergies, and the fact that she's very young and complaining of myalgia, the particularly rapid progression of the ILD and all that. So in that regard, the ANA pattern becomes very useful, particularly in low resource settings like ours, where the extended panels are very, very expensive. In such cases, if you have a reliable laboratory which can interpret this immunofluorescence assay in a correct manner, if they tell you the pattern of immunofluorescence, that can give you a basic idea about what is the possible underlying antibody that you're talking about, or what we call the sub-antibody. Because anti-nuclear antibody is basically an antibody against the whole of the nucleus. So it is very non-specific. Any nuclear antigen that is positive is going to give rise to a positive anti-nuclear antibody. But depending on the staining pattern, you can have a basic idea. For example, if the staining pattern is a nucleus homogeneous nuclear pattern, usually speaking, the sub-antibody that we are looking at is anti-double-stranded DNA, anti-DS DNA. So the other way around is also true. Now, in this picture, you can see that it's a nice nucleus speckled pattern. So in a patient who has speckled pattern antibodies, don't try to do dsDNA because it's not going to be positive. So like when you are doing targeted investigations, that is of value. So there are few values to answer your question directly in like the staining pattern of the ANA. One thing, it can predict what is the underlying antibody, the specific antibody, to a certain degree of certainty. And the second thing is, it can give you an idea about what sort of underlying connective tissue disease that you are looking at. But you need to remember, it all depends on how accurate the laboratory is, because these are not machine reads, these are interpreted using the human eye. So depending on how experienced the person who is reporting the ANA is, ANA can be a very useful investigation based on the staining pattern.
Yeah. Thank you, Chathurika. Based on this discussion, would you recommend extended autoantibody trial? Mind you, this patient can afford investigations. I mean, it's quite unfortunate we don't have this facility available in the government sector, but she could afford, and if there's no economical kind of constraints for this patient, do you recommend ENA panel for this patient? Yeah, great. So we'll see how the answers are. Yeah, there are about 65 has been responded, and the majority says yes. And so therefore we did this ENA panel actually for this patient. And so these are the results. So in this study that we found, I mean, again, that you have to be pretty careful when you're interpreting the ENA profile. There are certain signal intensities that they are talking about. We should see what is the intensity level and then decide what is significant. So I'll ask Chathurika again, my colleague, to discuss about the autoantibodies and what you can kind of, is there any significance of these autoantibodies? And if there's any significance, what do you think about it?
Thank you, Dr. Amila. I will need your help though in reading that. I'm so sorry, I can't read the script. So the ones that are positive.
It is RNP/SM antibody that is equal to U1 RNP is strongly positive. The intensity is 105. The upper normal is 25. And the SM antibody is 32. Again, it is strongly positive. But again, it is, and then we have a borderline positivity of SSB antibody.
Okay, thank you. So yeah, that is very interesting. So at the get-go, you said that the patient could afford. So then I would go with yes, because otherwise ENA panel we can very rarely get done because of the cost. But yes, in a patient like this, it is going to predict you the prognosis. It is going to tell you what sort of treatment is going to work for the patient. So it's an amount that is well spent, I would say. And the positive antibodies, the U1 RNP is strongly positive, which I think is like more towards one of the diagnoses that I was thinking about. But then U1 RNP plus the anti-SM both positive is a bit dodgy, if you ask me, because like we don't expect both of them to be positive at the same time. But on the other hand, U1RNP is a very non-specific antibody. That is the reason why, like when we talk about the diagnosis of mixed connective tissue disease, MCTD, the diagnostic criteria requires the anti-U1RNP to be positive in extremely high titers. There are two sets of criteria that we use, Halakun and Kahn criteria. And you either says like 1 in 1,200 or 1 in 1,400. The positivity has to be. The reason being U1RNP is very, very non-specific, not like the anti-SM antibody, which is highly specific for SLE. But however, having said that, here the very high positivity of anti-U1RNP SM antibody, I think I would take that as the most likely one here, the others being non-specific.
Yeah, definitely. So this is an evolving disease. I mean, she has been normal before, now her skin is changing, the fingers are changing, and she had a rapidly progressive IL. Initially, she straight away came to ICU, and which require non-invasive ventilation, and then recovered, and again there's another possible exacerbation that once she stopped treatment. So these are very evolving disease, and she has significant muscle pain, even though that we have this positivity. I'm just wondering, I mean, she thinks again that, I mean, whether you could exclude myositis in this patient. So that is my next question. Having normal CPK levels, can you exclude myositis completely? This patient has U1RNP positivity and there's CTD, two exacerbations which I'm very worried about. Yeah, please answer. Please give your answers. Right, again, about 67 responses submitted, and 84% says no. Do you agree with the responses, Chathurika?
Yeah, completely. So, like, it is very important to remember that normal CK does not say that there is no myositis. It depends on a lot of other factors, maybe to do with the muscle bulk of the patient, maybe to do with how much of inflammation is there in the background. So many factors. So normal CK does not indicate myositis, as well as just slightly high CK does not indicate myositis. So it does not exclude, does not indicate. I agree.
Yeah, so therefore we again proceed with the myositis profile, which is extremely expensive. Remember, this patient can afford it actually. So this we proceed with the myositis profile for this patient. So this is a myositis profile, and again I'll read it for you. That there's positivity for KU, positivity for PMSCL75, positivity for PL7, and positivity for OJ antibodies. And then depending on this, what is your underlying diagnosis of CTD? So it's a bit complex here. Many antibodies positive. Again, if I tell that it is KU, PL7, OJ, and then KU, which are single, 1+ positive. So what do you think? What is the overall diagnosis?
Okay, if you ask me.
Give me a second.
Yeah, okay.
So we'll see what's the audience decides. Right, okay. Yeah, about 65 responded actually, that 39%. So about they are still thinking about MCTD. About 22% they are thinking about antisynthetase syndrome. 16% they are talking about systemic sclerosis and SLE. Yeah, Chathurika, it's very complex. I know that.
Yeah. It is very complex, but if you ask me, I would rather go with the diagnosis of MCTD. The clinical picture and the antibody profile, I think, is more in favor of the evolving case of MCTD. One thing that I also have my concerns regarding the myositis antibody, because the myositis immunoplot is extremely expensive. It's not just like extremely, it's about 70,000 rupees from what I know. So I have only 2 lucky patients who were able to get that done so far. So almost never we do it. And the other thing is like antibodies, when you request, it has to always be guided by the clinical picture. So if the clinical picture is not that of an inflammatory myositis, idiopathic inflammatory myositis, antibodies can tell you very little. And the other thing is in that immunoblood, if you looked at that, there were so many that were positive. There were about 4 different types of antibodies that were positive, which is immunologically not possible because most of these antibodies they're mutually exclusive. So if one is positive, the other one has to be negative. So which means that probably the lab technique is not up to the benchmark. Maybe that is a possibility. So overall, the clinical picture, I agree with the majority of you. It's going more in favor of MCTD.
Yeah, again, actually, I totally agree with Chathurika. There are two principles when you are interpreting myositis profile. There are muscle-specific antibodies and muscle-associated antibodies. So the muscle-specific antibodies are MI2, MDA5, NPK, JO1, PL7, PL12, EJ, OJ. These are all muscle-specific antibodies. Remember that muscle-specific antibodies are mutually exclusive. So there can't be many antibodies of that. If one antibody is positive, that antibody inhibits the other antibody. So therefore, if it is muscle-specific antibody, remember it would be only one. Right. So we'll move on. And so this patient has a diagnosis. I think we all agree with MCTD. And we'll proceed with the next. So this patient had undergone lung functions. And initially, after the initial recovery, there's a moderate restriction. But with the current default of treatment, her lung functions declined. FVC declined to about 1.28, about 42%. And the DLC is now coming to the category of less than 40%. That is very worrying for this lady, young lady. And now she's 29 years, but now she's desaturating on exertion. She was previously fine, but now she's baseline is 92%. And on exertion, it drops to about 86%. So now we have a problem. So I'll now move to Sumudu Madam, and we have the HRCT of 2021 where she presented to the ITU straight away with the pneumonia. So would you mind commenting about this first CT scan? So you can see the axial images of the CT scan. I'll come to you after the audience responses. You can see the diffuse involvement of the lung.
Yeah, thank you, Amila.
I'll come after the audience responses, madam.
Right.
Give me a second. Yeah. So, what do you think? What is the radiological diagnosis? I hope you got right. Yeah. So at 45, they thought as NSIP 40%, and 32% they think NSIP OP, and 17% they think about UIP. And what do you think, madam?
Okay, thank you, Amila. Can you do another run?
Yeah, definitely. Stop.
Oh, that's it. Okay. So what we see is a basal predominant ILD. So if we consider the HRCT characteristic that we see there, so there's basal predominant disease sparing the extreme basal subpleural lungs. Now that type of appearance we do not see in many studies. We see especially in NSIP. So bilateral, basal and subpleural predominant interstitial lung disease with reticulation. And there's I saw some traction as well, especially along the bases. And as we go towards the apices or the upper lobes, we can see some patchy pleural base and some peribronchovascular shadows as well. So the basal appearance I would consider as NSIP type ILD. Now, those days, like we used to say it is NSIP, but now when we report what we say, it's NSIP pattern rather than so, because there could be so many other diseases with the same pattern. So, and then when it comes to the apices or the upper lobes, this patchy distribution, the patchy shadows, could be due to an organizing pneumonia. So most of the time, these two entities coexist.
Yeah, so yes, madam, I totally agree with you. So this is a NSIP OP. So this patient has acutely worsening of shortness of breath, which required ICU care, and with the immediate pulsing of methylprednisolone and cyclophosphamide. And in fact, this patient received rituximab as well, and she received anaphylaxis for rituximab, but she survived the initial acute exacerbation. So it is NSIP OP radiologically, and so this HRCT in 2025. Once she defaulted the treatment, and again, I'll ask from you. I mean, just please look whether there's any radiological progression or not, and if there's any progression, what is the progression? Please what? Yeah. So we'll see. Yeah, about 78 responses submitted and 48 things. It's about 50-50. It's very difficult for you actually. Yes, audience is divided. Madam, what do you think? Do you want to run again? Yeah. So jury is with you.
Okay, so overall the distribution of the disease is the same, but towards the bases, we can see more reticulation and more traction, broncholectasis. And the previously, we see like quite a volume of acute inflammatory changes with ground glass and interlobular interstitial thickening. So I feel that in the interval, there is worsening of the fibrotic component, that is the progression of the fibrotic component, with the overall disease distribution remaining somewhat stable. When you come to the APCs, I see slight reduction in the subpleural patchy infiltrates. So that means the organizing pneumonia component has somewhat come down. So that's what I think.
Yeah, exactly. I think so. This patient has progressive fibrosis. That's the concern, and this patient has evidence of traction bronchiectasis and bronchiolectasis. And the ground glass that you see, most of them are intralobular septal thickening, which is which can be interpreted as ground glass, but they all fibrous. So this is very worrying for a 29-year-old lady. And so her lack of adherence is due to pregnancy expectations. There's a lot of pressure from the family that she wanted to get pregnant, and therefore she discontinued all the treatment. And we did echo, but there's no evidence of pulmonary embolism. Now the question is actually whether we are going to recommend pregnancy to her or not. So based on these clinical parameters, what is your response? Are you going to recommend pregnancy or not, or maybe? Well, yeah. So 80 responses submitted, and about majority thinks that we should not recommend pregnancy. What do you think, sir?
The problem is with this degree of deterioration of lung functions and the dyspnea. The problem is whether she will withstand a pregnancy. So that's the problem. So first of all, you have to stabilize for thinking about pregnancy. So I think this is not the moment to think about pregnancy. First, you have to treat her properly and then achieve a remission before you think of pregnancy. Otherwise, you will lose both the baby and the mother.
Yeah, the worry is actually she developed already pulmonary fibrosis now, and with the pregnancy, we are worried about she might develop pulmonary hypertension during the pregnancy. So that's a killer for both mother and the baby. So actually, we can convert azathioprine because MMF has some heterogeneity, but that is not the case here. She developed into fibrotic disease now, and she has a very high risk of pulmonary hypertension, which can lead to death, maternal and both fetal death. So we can't recommend pregnancy. Now we have situation. So now we have a patient who has initially come with acute exacerbation of ILD. Now there's a progressive ILD, and she defaulted treatment. So what is your management plan? What are the options that we do have? Yeah, so majority things you have to treat with both mycophenolate and antifibrotics. What do you think, sir?
Yes, definitely. I mean, because basically earlier we saw a situation where there's the inflammatory changes are more, and now it's progressing to fibrosis. So the treatment initially would have been immunomodulator drug, but now since it's progressing into more fibrosis, definitely you have to think of adding antifibrotic. So I think I agree with that answer that it has to be treated with both MMF and antifibrotic.
Yeah, again, actually, she has lost quite a significant volume of lung now. The problem is actually because he discontinued this treatment for a while, and when you're starting both these drugs to a patient who is having problem with the compliance, that might be a issue. That is because that you have to establish on a one particular drug and then sequentials are antifibrotic. We have to start both. Actually, there's no question about that. But I think we should start on MMF and establish on that particular drug, wait for about 3 months and which is happy, and then start antifibrotics. But again, we have to start them simultaneously, but we have to make sure that she's not getting any side effects. This is a very tricky situation, and she might discontinue all the drugs and she might just start some other treatment. So it's a very interesting and challenging case. The discussion was really difficult with her, and ultimately we restarted her on mycophenolate. At the moment, she's on mycophenolate. So our next case is presented by Disney, and she's a senior registrar in respiratory medicine working with Dr. Bodhika Samarasekara at the National Hospital for Respiratory Valisara. Over to you, Disney.
Thank you, sir. So this is our case 2. This is a case of a 48-year-old male patient who presented with a 5-day history of hemoptysis, which was progressively worsening, shortness of breath, and chronic dry cough for about 8-month duration. And initially, his first presentation was 8 months back, and which was treated like pneumonia while he was in South Korea. And he denies any history of constitutional symptoms like loss of appetite, loss of weight, or fever. And there is significant occupational exposure, including 3.5 years he engaged in steel industry, where he directly exposed to mineral dust. And also, there's a significant exposure to poultry for about a 6-year duration. And there is no feature suggestive of connective tissue disorders, and there is no history of previous tuberculosis. And he was an ex-smoker and with a pack year of less than 2, and he has stopped the smoking 8 months back. Regarding the clinical examination, on general examination, there is no features of clubbing and no peripheral stigmata of connective tissue disorders. Respiratory examination revealed there is saturation was 97 in room air, and bilateral inspiratory crackles and reduced air entry in both lower zones. And bronchial breathing patch was noted in left side upper zone. And rest of the systemic examination, including cardiovascular, neuro, and abdominal examination, were unremarkable. So rest of the discussion will be handled by Amila sir. Over to you, sir.
Thank you, Disney. Yeah, so the problems again, I mean, this patient has hemoptysis for 5 days duration and progressive shortness of breath for 8 months, and there's chronic problems, significant exposure, various dust, steel fumes, and poultry exposure. He was kind of involved in chicken farming. He's an ex-smoker, and then he has a lot of financial difficulties and potential problems. He might, again, I mean, we might think about he might progress to end-stage lung disease, whatever the disease. And there's a history of, I mean, there's a significant risk of a cancer here because he's an ex-smoker, exposure to steel, dust, and fumes. So, so my first question to you: what are the likely diagnoses in this patient based on the history and examination? Right. So they do think all of the above possibilities, and there's a 31% they think there's a possibility of HP here or pneumoconius. What do you think, sir?
The thing is, now this patient has hemoptysis and shortness of hemoptysis. Now, if you its hemoptysis makes ILD, pure ILD is very unlikely. Because for you to get hemoptysis, either there has to be a cavitative disease or a pulmonary vasculitis. So, therefore, and infections definitely, infection is a possibility, and chronic infection. And pneumoconiosis, high HP. The problem is she has been exposed to mineral dust usually, so you get on exposure to inorganic dust, you end up with pneumoconiosis, and on exposure to organic dust, you end up with hypersensitive pneumonitis. So she has a history of both getting exposed to poultry as well as steel. So there's exposure to both inorganic and organic dust. So it could be either way. So in that sense, that I think at this stage, I mean, you don't have much. You can't pinpoint that this is this. So you have to think of all those reasons before you start investigating this patient further.
Yeah, thank you. So, I mean, one of the things that I would like to highlight is actually this. So this patient has a red flag symptom. So when you have a red flag, always you have to think of sinister. This patient needs a lot of investigations. So hemoptysis is a red flag. Whenever a patient comes with whatever the background problem, if there's an hemoptysis, you have to think about two conditions. One is the infection, other one is a malignancy. So these both are possible here. And ILD is pure ILD per se, as Sir said, might be less likely, right? But again, hemoptysis, remember, it's a red flag that you have to always think about. The next slide. So these are the basic investigations of this patient. So patient has been WBC is normal, CRP is normal, ESR about 20. And the sputum we have done extensively negative, gene expert negative, BORN2 negative. We did some autoimmune screening that later on, which is rheumatoid factor negative, and AN is 1 in 80, cytoplasmic and nuclear patterns. The UFR is normal. HIV screening we did because of suspecting infection, and which all are normal. Chathurika, what do you think about this ANA 1 in 80?
With ANA, particularly when you are doing an ANA in a background of possible infection, you have to be very careful, because infection alone can give rise to a positive ANA, and particularly when it is in a mixed pattern like this, cytoplasmic and nuclear, it becomes very difficult to interpret the underlying sub-antibody pattern. You can't basically. So they will say like it's a mixed pattern, so you can't predict. So my argument here is like the pre-test probability of this being a CTD-related ILD is pretty low, in which cases the predictability of any form of positive ANA becomes very low. So I would disregard this unless there are other features of a CTD suggestive of a CTD cropping up later on.
Exactly, yeah. So this low titer 1 in 80 and mixed pattern, usually that is not very significant here. And then again that we are thinking of a possible infection on top of that. So again, in this case, remember there are no CTD features. Would you, this patient, again, financially constrained. Do you think you should go into the ENA in this patient? Yeah, good. Most of the majority, they're thinking that we should not do ENA here. I also agree with you. As Chathurika said before, this is a very non-specific pattern. And also the patient has, there's no significant clinical features of CTD. Then we did a lung function in this patient, which is about restrictive pattern, and there's no desaturation on the lung function. But this is the X-ray of this patient. So please look at the X-ray. And then based on this X-ray, we did all these investigations, and then we did a HRCT of this patient. So, yeah. So these are the axial images, and then you have the coronal images as well. Sorry about this quality. So could this be secondary to the same pathological process, or it could be different? What do you think? Right. So the majority think it could be due to two pathologies. And yeah, I think initially, there's a cavity and then there's some fibrosis. We'll ask from our expert. And also that before that, if it is due to two pathologies, what are the possibility for the cavity and consolidation? Yeah, so they think all of the above. And I'd like to ask from Madam, with the radiology, do you think all these are possible, or do you have any specific diagnosis? But before that, I'll go to the next question as well, then you can comment about that, about the other problem. So what is the pattern for the ILD? Is what? So now you have history as well. Usually, madam, you don't get the history, right? But now we have a clear history now of this patient and examination. And yeah, we'll see what is there. So they think 48% think it is 50% think it's UIP. And for the first pathology, they think all of the above, all of these possibilities are there. So what do you think about this CT scan?
Shall we go for another run?
Yeah.
In the axial?
You want to stop there?
Yeah, just stop there. No. In the middle of the cavity, like if you can stop.
There you go.
A little bit, right, yeah, okay, right. Fine. So we'll start from the cavity. So, so we have a very well-defined, like, I would call it thin-walled cavity, which is fairly clearly defined. And there are few, we can see some parenchymal bands just in the periphery, but there's not much of distortion associated with the adjacent lung. Now, that is what we would expect in case of a tuberculous cavity. With tuberculous cavity, there's a lot of lung distortion and scarring. On contrary, in fungal cavities, sometimes you can have a very fine defined wall with not much of wall thickening, right? You may have or you may not have an intracavitary body, doesn't matter. But compared with if you're comparing infective causes and if you're comparing a cavity due to tuberculous and cavity due to fungal, the fungal cavities will be more defined and fine, right? So if you are thinking in line of infection, I would go for fungal cavity rather than tuberculous cavity in this case. And the other thing is vasculitis. Now, this patient is presenting with hemoptysis. So, vasculitis also could cause cavities, but in that instance, we would see some ground glass surrounding it, especially since the patient is presenting with hemoptysis, right? This one, I'm not seeing any ground glass around it. So I would disregard that possibility. So I will go more with the fungal cavity. So as we go down, yeah, there is, if you can stop somewhere in the middle lobe. Somewhere there, yeah. So in the middle lobe, we are seeing a focus of consolidation. So within that, I can't see any cavitation or surrounding ground glass. It's just a consolidation. It can well be infection or it can be well be malignant. So at this point, with these images, I cannot further define. But since the patient is coming with hemoptysis, with the background, first we have to exclude infection, for example, focal pneumonia or something, before going into something invasive to exclude or further characterize it. Right. So if we go to the bottom.
Yeah.
A little bit more. Right. Just a little bit up, just if you can see the extreme bases. Okay. Right. Shall we go to the coronals now? You can a little bit, yeah, if you can stop somewhere there. Okay. So in the bases, we can see some fibrotic interstitial lung disease. From what I could see from these, there are some honeycombing. Traction broncholectasis actually, it's a bit too much to define with this definition. But there is basal fibrotic ILD, which involves the extreme posterior recesses, right? So the ILD, fibrotic ILD, which usually involves the extreme posterior recesses, is UIP type, right? So this patient may be having multiple diseases. So this is UIP type, that is what we call it, UIP pattern ILD, not possibly due to IPF because the patient does not fall into the age category. So UIP type or pattern ILD, and then incidental finding of segmental consolidation, for which we have to exclude infective causes, and also incidental finding of a cavity in the left apex, which could be post-infectious, possibly fungal. So that is how I would interpret it.
Yeah, thank you. And I would agree with you, madam. I mean, thank you for that kind of detailed examination. So there are a few things. I mean, this is UIP, but it's an odd presentation. Young patient coming with UIP. There's a lot of exposures. There are a few things that I would like to highlight apart from what madam said. There are a lot of honeycombs and the traction is low. So that is called exuberant honeycombing. They say more than 70% of the fibrosis is due to honeycomb, that is exuberant honeycombing. And you can see the sharp edge. You can see that normal lung is sharply demarcated by the fibrosis. That is called sharp edge sign. Another one is actually that if you see axial, there are anterior upper lobe signs. There are some fibrosis in the upper lobes as well. So these things they say it could be UIP, but they are more specifically to underlying CTD. So if you see this UIP pattern with exuberant honeycombing, sharp edge sign, and anterior upper lobe sign, that could be due to exuberant honeycombing. So so we'll proceed. And so what is the likely etiology for this ILD? What do you think? Yeah, I discussed that actually. I mean, you have to think about CTDs and exposures, but when you have this exuberant honeycomb and all, you have to think about possible underlying CTD. Even though this ANA is less, I mean, not very sensitive. So that's fine. So what is the next investigation of choice, please? So this patient has fibrosis, there's a cavity, and madam thinks it's fungi, and there's a consolidation in the right upper lobe, anterior segment, left upper lobe, there's a cavity with a smooth margin, and there's no peripheral destruction around the cavity. So very interesting. Yeah, majority think bronchoscopy, and some think CT carotid biopsy, and some things about all of the above. Actually, this patient had bronchoscopy. So we are thinking about more sinister causes now, and there are cavities and consolidation. We are thinking of infection. So this is what the bronchoscopy findings are. So we found a lot of mucus plugs, and the main carina was normal. Right upper lobe anterior segment was completely blocked with mucus, and there's a mucosal bulge that we did biopsies, and this biopsy histology was normal, but the biopsy we sent for fungal cultures. I mean, this patient is from Gaul, so when you see these abnormal presenting, we send biopsy for fungal cultures most of the time because it's quite common fungal. I mean, we have a lot of fungal disease around Gaul. So this gone trichosporon species is not a very common fungi, but it's been associated with fungal infection. But this fungi is not a very common pathology. It's a biopsy, remember. And then galactomon is marginally elevated, and rest of the cultures is negative. TB, gene expert, everything is negative. So initially I had a chat with Prof. Denning, so that he would be around for this discussion, but he's not around. But the most classical, and we have done the fungal serology sense, and IgG was negative for Aspergillus. Galactomon is only marginally positive. So what are the management options for this patient? Yeah. So basically, I want to know whether we should start treatment for the ILD, whether we should start for the antifungal. Yeah, so that the decision was to start antifungal treatment with antifibrotics. That is a majority, and then second, they think antifungals with immunosuppression, and then third option is antifungals, antifibrotics, and immunosuppression. So, what do you think? So it's a judgment call.
So now you have a cavity with bronchoscopy showing fungal filaments. The biopsy. Yes, radiologically also. Yes. So giving antifungal is one of the options. I mean, you have to treat these patients with antifungal. But when you go lower down, the fibrotic changes are more than the inflammatory changes. So there is no question of giving immunosuppressives. So it has to be antifibrotics. So I think I will vote for antifibrotics with antifungals.
Yeah. So what we did actually, we had some discussions with some mycologists, Dr. Samhita Srigera, and also that we were a bit worried about this patient because this patient has a large cavity. He presented with hemoptysis, so we decided that we should prioritize the fungal treatment. And so we decided to go ahead with only antifungals because we felt that the disease is quite stable for 8 months, and even though it has some breathlessness, and we don't want to complicate because antifungals are really difficult to kind of they have a lot of side effects. I'm sure that you have prescribed voriconazole and amphotericin. They have quite a lot of side effects, and especially voriconazole, the severe headaches and photophobia, and you get all sort of side effects. So therefore, we thought we are not going to kind of start any treatment for the ILD. We thought it will be observed, and then we decided to go ahead with antifungal. So we started on voriconazole based on our expertise opinion. And this patient, therefore, since that this is the latest X-ray actually after the treatment. You can see the cavity is reduced, and there are no more hemoptysis, and so cavity is getting better. But this patient did not complain of any hemoptysis, but the problem, he now complains of some appetite loss and weight loss. There's a concern. Now what we should do? That is our last question. And appetite loss. Yeah. While on antifungal treatment. We'll see what this is. Yeah, so they want to re-evaluate this patient with imaging and plan for further investigations. What do you think, sir?
I mean, his loss of appetite and weight loss could be due to antifungals, and it could be due to some other thing. I mean, now along with those that bronchoscopy, you must have done bronchial watch for TB culture and all that. So TB is out. And what about his shortness of breath? He doesn't complain of shortness of breath. Still stable and and the other thing is, what I notice is that though there are a lot of fibrotic changes, there's no loss of lung volume. So loss of lung volume, maybe he's a smoker and exposed to, so there is an element of airway disease also. So short, so first, adding antifibrotics, immunosuppressives is completely out, because if you on top of this, if you add immunosuppressives, he will get the fungal infection again. So whether to now that the fungal infection has subsided, you control. I mean, you have to think of another exothoracic cause for this weight loss and appetite loss. That is one thing, because if the fungal infection is under control, the interstitial lung disease part per se cannot give rise to weight loss and appetite loss. So you have to find a cause for that. And the other thing is whether we are going to start this patient on antifibrotic, because if his interstitial component is stable, adding antifibrotics can make this loss of appetite and the things worse. So it's a bit of a complicated situation. So
yeah, definitely. I think I would agree with you, sir. Actually, I mean, we should have open mind here. And this fungi is kind of a very, very kind of rare fungi. So therefore, we have to kind of think laterally, and we have to further investigate, do a CT scan, do thyroid profile, and see if there's any thyrotoxicosis and all. So yeah, so it's very complicated. So we'll investigate this patient further and let you know what is the outcome. And thank you so much for this. And so we have kind of run out of time. I'd like to thank all the faculty and all the consultants that who supported. And then please feel free to give us a feedback about this ResFire ILD and whether this interaction is, you're happy with this interaction, whether kind of you do more like more lectures and all. So thank you so much. I'd like to thank the faculty again. Thank you so much. And we'll conclude the sessions here. Thank you.
A small notice to everyone in the hall. We will start this prize giving for scientific session and along with the raffle draw immediately after. So please remain in your seats. With that notice, it's my sincere gratitude to our esteemed panel for your contribution on this pivotal topic. Let me invite Dr. Ranjan Disanayake to present the token of appreciation to the panel of experts on the session and the resource persons. Dr. Amila Rathnapala, Dr. Vijith Senaratne, Dr. Chathurika Dandeniya, Dr. Sumudu Palihawadena, Dr. Disney Disoisa, Dr. Oshadi Kehel Ovitigama. Thank you, sir, madam.